webinar talking about the COVID-19 vaccinations for students ages 5 to 11. We're excited to have you here with us tonight. We have a couple hundred participants. This is a webinar with a question and answer period at the end of the period, and so you'll get a chance to ask your questions, and we'll do our best to answer them either in person or in writing. I'd like to make some introductions before we get started, and we have several folks who are here as panelists and present with us tonight. I'd like to welcome Dr. Cal Gordon. He's a pediatrician and works with public health. Welcome, Dr. Gordon.
Thank you.
I'd like to welcome Dr. Raylene Walker, who's a local pediatrician and immediate past president of the chapter of the American Academy of Pediatrics. Welcome, Dr. Walker.
Thanks for inviting me.
And I would like to welcome our district superintendents who are here. I'd like to start with Eric Rose, who is the superintendent of Pacific Elementary. Welcome.
Thank you.
Michelle Stewart, district superintendent for Happy Valley.
Good evening.
I'd like to welcome Megan Tresham, who is district superintendent for Mountain Elementary.
Thanks, Barris. Hi, everyone.
Mike Hefner, who is the superintendent for Bonnie Doon Elementary. Welcome.
Thank you. Good evening, everybody.
I'd like to welcome Tanya Kraus, superintendent for Scotts Valley Unified School District.
Good evening. Thank you, Ferris.
Thank you for being here. Scott Turnbull, who is the district superintendent for SoCal Union Elementary.
Thanks, Ferris. Good evening, everybody.
I'd like to welcome Chris Monroe, a district superintendent for Santa Cruz City Schools.
Ferris, good evening.
Good evening. And Chris Schermeyer, district superintendent for San Lorenzo Valley.
Good evening, everyone.
Thank you so much for being here. I'd also like to welcome Neida Poblete, who is a representative with Inspire Diagnostics and helping to coordinate our vaccination effort here in Santa Cruz County. Welcome, Neida.
Hello, everyone. Thank you.
As we get started this evening, we'd like to share with you that we're going to be offering a COVID-19 update. We're going to talk about our efforts to keep students safe and our schools open. We will talk specifically about our voluntary vaccination effort for students ages 5 to 11 years old, and talk about how we're hoping to implement those vaccinations and the different options that parents and community members will have for their children. And we will also open it up for questions. People will have an opportunity to be able to ask their questions. Since this is a Zoom webinar with a Q&A feature, we're asking everybody to utilize the Q&A feature, which is the button that is probably at the bottom of your screen that says Q&A, and that will be your opportunity to be able to ask questions. And we will do our best to either answer them live over for everybody, or be able to answer you directly in writing as much as we possibly can. We want to thank you so much for being here. Thank you for being a part of this important conversation and for joining us in this webinar this evening. I'd like to turn it over at this point to Dr. Cal Gordon, who's going to be talking to us about some recent updates in relation to COVID-19 cases.
Thank you so much, Ferris. And just again, as an introduction, I'm Dr. Cal Gordon. I've been a pediatrician for more than 40 years, and I would note that I am a product of the Santa Cruz County educational system. I went to Scotts Valley Elementary and middle school, graduated from SoCal High School, and actually did undergraduate at UC Santa Cruz. And I've been working with public health since the beginning of the pandemic. So I'd like to provide just a bit of an overview about COVID and children. And I would want to note that there's, I think, been a sense that somehow children are not impacted by COVID. But I think after this evening, people will accept and realize the extent of whether it's been infection or the effects of COVID on children. Up to the last pandemic surge with Delta virus, we had relatively low presentation of children that became more pronounced during the last winter surge. And then with the Delta virus surge, actually we're overrepresented in terms of percentage of total number of children in our population. And this was marked all across the country. So we've had on the order of 5.9 million pediatric cases since the beginning of the pandemic, with something on the order of 47 million cases occurring on a national level. And just last month, we had 850,000 pediatric cases, which is 1 out of 7 of all the pediatric cases to date with the pandemic, just in that single month. If we can move to the next slide. Again, of the 100, there were of the total of 100 COVID hospitalizations, 2 to 4 have been children. Most recently, we had on the order of 620 more children that were hospitalized in the past week or a couple weeks ago. And there were more than 22 children that died from COVID. And we've had more than 650 children die from COVID since the pandemic began. Next slide. In terms of the vaccination, we've had 13 million vaccinations that have occurred with our 12 to 17-year-old population, which is 56% of that population. And we've also noted that for unvaccinated adolescents, they were hospitalized 10 times more than their vaccinated peers who had COVID. Next slide. Just an update on boosters, because last week there were some booster recommendations. Those are recommended for people who are 65 years of age, for people over 18, people with underlying medical conditions who work or live in high-risk settings. And with the Pfizer, Moderna, and Johnson & Johnson, there's been agreement for the third dose. You can do a mix and match if you wish. So again, people can get any brand of booster regardless of their initial vaccinations. Next slide. On a more local level, in the past month, we've had 229 cases of COVID. Again, we looked at a national level where it was like a 10-to-1 case of kind of people being hospitalized. That was also true in terms of the 10-to-1 ratio of who got infected. You're like on the order of 10 times more likely to be unvaccinated. And we had one youth that had to be hospitalized during that time. Next slide. Again, we've done better than the national average. We have 71% of our 12 to 17-year-olds have been fully vaccinated. And interestingly enough, we have a higher percentage in the South County as opposed to the North County. Next slide. The other part is that there's not just a direct piece of children getting COVID, but there's been a real toll on children in other ways. 150,000 children nationally have experienced the death of a primary caregiver, like a parent or a grandparent. There's been, both locally and nationally, much more mental health issues, whether it's suicide gestures, thoughts of suicide, depression, anxiety, behavioral developmental concerns, eating disorders. All of those things have actually gone up in a significant way, both locally as well as nationally. We've seen a dramatic increase in diabetes. And then we all, I think, have experienced where because of last year and the inability to stay in school, there's been loss of learning, which was really increased for those people who don't have access to online learning capability. And there are children who have had long COVID. And I think that everyone has probably been touched by COVID at this time in one way or the other, whether it's family or neighbors or friends. Next slide. I think this one's yours.
Thanks so much, Dr. Gordon. So I would like to just talk to you a little bit about what our schools have been doing in conjunction with the partners, with our local public health office, with Inspire Diagnostics, to do everything that we can to create a safe environment for our students and our staff. And we often share this slide to show kind of the different layers that we put in place to help protect students and protect our staff when it comes to COVID-19 in our schools. And this includes having screening systems so that we make sure that if students or staff are sick, that they stay home. We collaborate with our local pediatricians to ensure that we're communicating and we're being consistent in our application of the guidance from the California Department of Public Health. The districts have invested in improving the air quality within the classrooms, including air conditioning, air purification, and opening of windows to allow to maximize outside air. We've implemented a robust testing program in compliance with the California Department of Public Health, with both PCR and antigen testing for students. And that has allowed students who have been exposed to others with COVID-19 to remain in school, as again, following the guidance from CDPH. We've implemented protocols for isolation and quarantine of anybody who, if isolated, if they have symptoms or if they test positive, quarantining folks that have been exposed to positive cases. And we've implemented the universal indoor masking requirements under CDPH direction. And of course, we have been offering staff and student vaccination. And we, when looking at the state data for vaccination, we'll see that we've been pretty successful in being able to vaccinate the majority of our students ages 12 and up at this point. As I shared earlier, our goal has been to do what we can to keep our schools open. We've worked to identify cases as quickly as possible. Most of the cases that we find in the schools are coming from the community and not coming from in-school transmission. We've established a testing program, as I described, in collaboration with Inspire Diagnostics at over 100 school sites across the county. And this has allowed us to be able to ensure that students who are exposed are able to quarantine at school as opposed to quarantining at home. And those are some of the pieces that we've worked hard to put in place on behalf of our students and our staff and our school community. I believe I'm going to turn this one over to Dr. Walker. Welcome, Dr. Walker.
Thank you. So to give folks a little bit of a background of what the American Academy of Pediatrics is, I just wanted to tell you what that is. So the American Academy of Pediatrics is a volunteer organization whose sole mission is to promote the health and well-being of all children. And it's a volunteer organization of primarily pediatricians, but also some nurse practitioners and physician's assistants. It's based in the United States, given the name, although interestingly, there are several Canadian province chapters as well. None of us are paid for our work at all. Although if we attend we do get some of our travel expenses reimbursed. So the process of developing this vaccine, I'm going to back up before the 5 to 11-year-olds. So there are a series of steps that go into the approval process for vaccines in the United States. And though this vaccine in many, many ways is very new, it is a fruition of many years of research. So starting in 1990 is when messenger RNA work was really taking off. And that has been, so for this 30-year process, there are essentially cancer mRNA vaccines that have been used in people for the for the purpose of treating cancers for the last about 11 to 12 years, not on a wide scale because they're based on very specific genetic differences in those people's specific cancers. In addition, it's been used, the same technology has been used for lots of other vaccines, again, very small numbers. So Zika, rabies, CMV, which stands for cytomegalovirus, which is primarily a childhood and an infant virus, and Ebola. And so though they seem really new, they're not as new as they seem. And this has been said by many, many others, but I wanted to repeat that every step has gone forward as has always gone forward. The biggest difference with the expedited studies is that they didn't require all of the administrative pauses and gaps. That's really the most time-consuming portion of that. So fast forward to this, the vaccine for 5 to 11-year-olds is the Pfizer COVID-19 vaccine. It is the very, very, very similar, though not identical, to the vaccine that has been given to 12 and up. In the studies that Pfizer submitted for this age group specifically, there were more than 2,200 kids studied. The findings were that it was incredibly safe. There was a single handful of adverse effects. One of the amusing adverse effect was, because they have to list everything, is a young child who swallowed a penny, which clearly had nothing to do with the vaccine. Very effective at preventing all infection. And we're going to get more data about the severity of the infection, but the 91% effective means that it prevented infection at any level in 91% of kids compared to the control group. To the control group. The dosage is 10 micrograms per dose, which is 1/3 of the dose for those older. And the goal was to find the smallest effective dose for this age group. And kids the younger they are, they tend to have a more robust immune response to many things. And so a 1/3 dose works really, really well for this age group. The FDA preliminary committee met on the 26th of this month, so 2 days ago, and the vote was 17-0 with one abstention in favor of moving this forward and supporting this. And there will be follow-up meetings on November 2nd and November 3rd for the American Committee on Immunization Practices to go over this in more detail. And then the process is that it goes to the CDC has to then review all of that and decide yes or no. And then the Western State Coalition will also independently look at that. The other small difference of this vaccine is that one thing with these is the pH needs to be maintained very stable. And so they changed the buffer just a little bit so that it maintains stability at temperatures closer to refrigerator temperature for longer. So this one can stay in a refrigerator for up to about 10 weeks is what we're currently, the studies we're looking at. So it's a little more hardy and doesn't require the super cold temperatures that we all were thinking about at the very beginning. Next slide. So one of the very, very big things, so particularly in pediatrics, we look long-term, we think long-term, we're very prevention-oriented, we are very cautious, we are very concerned in general about unintended consequences. Fortunately, most kids, heal from most things really, really well. And so to a large extent, our goal is to facilitate the natural healing of children and provide them with the things that they need for their body to do it on their own. There have been issues of myocarditis and pericarditis in COVID infections. There have also been issues of myocarditis and pericarditis in vaccine recipients without infection. So what these are, so myocarditis technically means inflammation of the heart muscle, and pericarditis, the pericardium is the sac that encloses and encompasses the heart. And so inflammation of the outer lining of that, the pericardium. And the immune system is known. We can get inflammation from a variety of things. Infections are a definite trigger, and vaccines can be a trigger. as well as other things. In pediatrics, very interestingly, exercise is a known trigger for not myocarditis, but for inflammation of the enzymes that we study to look for myocarditis. So I'm going to come back to that, but troponin levels has been something that people, that we measure, that we look at in adults. That is very much a part of looking at heart disease and whether or not someone's had a heart attack. And that has added to some of the confusion and complexity of this topic. So this can be extremely mild to a little bit of chest pain, but absolutely stable vital and normal vital signs without any evidence of functional abnormality. It can also be very, very severe, and in very severe myocarditis, that can be fatal. And that's just in general. I believe the next slide, we're going to get into a little bit more detail of the two things. Okay, so COVID infection, one of the big problems is that it causes inflammation, and it can be inflammation in numerous parts of the body. And in pediatrics, especially with the miscellaneous inflammation syndrome of children, that is, one of the most severe aspects of true disease. And the heart is one of the most severe. So lung disease has been more of an issue in the adult population, for sure, though it can be in kids as well. COVID infection causes somewhere on the order, there are multiple studies, but between around 30 to 37 times more myocarditis than the vaccine, even in the highest risk age groups. And it is a completely different entity. The myocarditis that has been seen with COVID infection is generally severe. It is generally much more prolonged, and it has, in many instances, required intensive care, hospitalization, and very involved medical treatments. The myocarditis that has been seen in post-vaccination primarily has been in adolescent and young men, but it is also young boys and men. It has also been in adolescent and young women, but to much lower extents. And it's been very rarely requiring hospitalization, mostly very self-limited and not requiring any active treatment, but just monitoring. Early on, there were concerns, a lot of concerns. We were extremely concerned in the pediatric, healthcare world about heart issues for kids because, no one knew anything about COVID until this whole thing started. And college athletes and other elite athletes were having troponin levels and echocardiograms of their hearts. And people were finding some elevated troponin levels. This is pre-vaccine. And that in the situations where it correlated with illness, they could be clinically ill. But there were lots of situations, particularly with more cardiovascular intensive sports like soccer and basketball, that young athletes can have transiently elevated troponin that is believed to be nothing that is clinically ill, and it's just a response to that exercise. So one of our big concerns is, of course, that winter is coming, and with indoor time increasing, with closer contacts, in the context of kids being in school, which, again, to emphasize and agree with what Dr. Sabah said, kids need to be in school for a variety of reasons. We are concerned that might happen. And so our hope and goal is to prevent the severe myocarditis infection related from the myocarditis related COVID infection by protecting them with the vaccine. Next slide. So the benefits of vaccination are numerous. Kids are much, much less likely to get sick. And if and when they do get sick, they are much less sick. So there's about a 93% reduction in hospitalization. Also, on a community and public health and family level, vaccinated children and vaccinated people are much less likely to spread it to anyone else. And that includes their own relatives, older family members, siblings, classmates with immunodeficiencies and other higher risk conditions. And it's the way that we can prevent kids and adults, anyone from contributing to more variants emerging. The Delta variant, of course, has been, particularly, more transmissible than others. We don't think it is more severe in children, but we do know that it is much more transmissible, and many more kids have been getting sick. So the bigger one is not death. So I as pediatricians, we have been a bit frustrated, I think, with the focus on mortality rates, because morbidity, which is the fancy term of illness and decreased quality of life and decreased mental health and decreased all these other aspects of health that are, you're alive, but they can be very, very, very huge issues. This has been so unbelievably difficult for kids. I know that mostly that you're probably parents that are participating in this. Pediatricians, every day, we are seeing so many, no kid has been spared. They are struggling to some degree. Some kids are struggling very, very little, and getting back to school has been phenomenally helpful. Some kids are continuing to struggle. We have an absolute epidemic locally as well of anxiety, depression, all of the things that Dr. Gordon spoke of. The learning loss is tremendous. And we know as pediatricians that this is going to impact kids long term. There are kids that are, they didn't just stay where they were 2 years ago. They actually have regressed in terms of their learning. There are also, concerns about kids don't know how to socialize in the same way. They don't know how to interact with each other. And so they really do need to be able to be in school and to participate in fun and play. Kids learn through play, and they need to be able to do that safely and happily and eagerly. Part of that is also being able to be part of their communities and, go to holiday events and birthday parties. And it's extremely hard. Everybody who has a child under 12 is in this kind of unusually difficult limbo right now, because those kids are not protected. And today and every day, I have parents, they're going to be able to improve their life and improve the life of their child after their kid is vaccinated, because they're going to be able to do more things without putting other people at risk or their own child. Next slide. I think this is back to Dr. Gordon.
You're on mute, Dr. Gordon. Before you get started, I just looking at some of the questions, I do want to clarify to our community members who are participating that vaccines are not mandated at this point. That parents have a choice whether they want to vaccinate their children or not. And after Dr. Gordon gives some information, I do want to talk a little bit about the governor's effort to make vaccines mandatory, but they are not mandatory right now. And so everything we're talking about is about a choice parents have to choose whether they want to vaccinate their children or not. Go ahead, Dr. Gordon.
No, that's fine. If I could just follow up on just what you said, Ferris, I would say it's our goal to provide you information about vaccines tonight, but I suspect that you may have additional questions, and I would highly advise you to talk with your own pediatrician, your own family physician, to talk through your questions. And this is a personal decision to be made. This is your child, and as a pediatrician, I firmly believe in vaccinations and what they have to offer. Early in my career, I saw forms of meningitis where I had children die or have severe retardation, that once we offered vaccines, I never saw it again in my career. And so there's vaccines have a real role in terms of protecting our children. I also would like to talk about just sort of where we're at in terms of the rollout for our 5 to 11-year-olds. The FDA, I think all of you know, approved for acceptance for the vaccines as of last Tuesday. This goes before the committee of the CDC next Tuesday. And as Dr. Walker noted, it actually goes through a third committee for it to be actually administered here in California, which is the Western State Scientists Group that does a third review of the vaccine. So we do anticipate approval by these other two groups, and it's our expectation possibly the end of next week or the beginning of the following week of November 8th for the vaccines to be available for administration. And when it is available, our county is ready. We have our schools that, working with Inspire Diagnostics, have 3 drive-through clinics, as well as sites at Cabrillo and Pajaro Valley, County Office of Education, and mobile vaccine vehicles that will be able to go out to the respective elementary schools so that there will be easy access. We also have our clinics, our medical offices at the Wattsville Health Center, Salud para la Gente, the Santa Cruz Community Health Center, Sutter, Kaiser, and Dignity. And again, this is, I think, where if you hopefully you have personal physicians for your children, and this is really an opportunity to engage in that conversation. Public Health also has a standing Wattsville Vaccine Center, which is the old courthouse in Wattsville, as well as vaccine strike teams that can come out and vaccinate in pop-up areas and sort of community events and other community sites. And we work hard to support our healthcare partners in the community. So I'll stop there. And Ferris, I know you wanted to speak about the governor's mandate.
Yeah, so, a common question that we get asked in the schools is, the governor recently, a couple of weeks ago, made an announcement that it is his intention to make vaccination for COVID-19 a requirement. And so to allow that, to be able to make that happen, it would require approval by several health agencies, including the California Department of Public Health. Now, if that takes place without legislative action, the requirement for children to have to be vaccinated with COVID-19 would have a personal and religious exemption. However, if legislative action is taken and the COVID-19 vaccine is added to the currently 10 required vaccines without a exemption, at that point, then the exemption would not have a personal or religious exemption. The vaccine would not have a personal or religious exemption. And so there are multiple steps. It would take time to be able to implement this. The earliest that we think that a mandate could be put in place by Sacramento would be in the fall of 2022. That would be for grades 7 through grades 12. And the earliest that they could possibly get approval for a mandate in schools for younger students, kinder through 5th grade, the earliest they could possibly put that in place would be for January of 2023. And so we wanted to clarify again that currently there is no mandate, and that we are simply providing this information, and parents have a choice to be able to decide if they want to vaccinate their children or not. All right, I think at this point I'm going to stop the share, and I'm going to start. I'm going to go to our to the questions. We have quite a few questions, and so we'll start with a question about. There was one question about masking. Is masking still going to be required? And the requirement for students to mask is established by the California Department of Public Health. At this point, they have required masking while indoors and recommended masking while outdoors. And they have shared that they are going to review this mandate by November 1st. They recently published a letter in which they supported the continuation of this requirement. So we anticipate that the California Department of Public Health is going to continue to require masking indoors as they have up to this point. Question, Dr. Walker, how much myocarditis is seen in kids ages 5 to 12? It says, I think they mean 5 to 11 with COVID.
I am not going to be able to say that number exactly, but I can do the math. So, it's about 30 times more than in the vaccinated population, but this question is specifically about the 5 to 11. I don't know the exact number, but it's, again, way higher than was seen in this study, which is admittedly very, very small. So this is something that would be absolutely monitored. So about 7 per 100,000. Okay, I'm not going to get the numbers correct. I'm going to back up and say I don't want to misspeak. And so I will find out the exact rate in that age group. I know more the kid age group, like pediatric in general, but I don't know the sub breakdown of kids 5 to 11. Cal, do you know?
I can't speak to that. Okay. I can't speak to that. I will note that for the study group of those people who participated in the vaccine study, there were no cases of.
There were zero, exactly. So we know that in the study there were zero, but that was out of the only,
a smaller group,
small number. But that was extremely reassuring and contributed to the dose. So for kids in general, I can speak to that, but the 5 to 11 is. I don't know that one, so I'll find out that subpopulation age group.
Another question: the question is, if the vaccine is safe, why are we giving a lower dose to younger children?
Because the lower dose is because it's effective at the lower dose. So the goal was always to use the very, very smallest amount of any medication or intervention. And it works really, really well with minimal side effects. So and we know, and that's also why, a common question I've been asked by parents is, is it okay that the dose is going to be the same, or the intended dose is the same for kids 5 through 11, because their size is quite different. There are 5-year-olds who are very small and have a very low body weight, for example, and there are 11-year-olds who are essentially adult sized. And it's not weight-based, it's based on the immune response, and that is much more age-related than weight-related. So the much lower dose is because it works.
If I could add to it, it works because this age has an amazing immune response to antigens, whether it's any sort of infection they get. They have a very strong immune response, and we'll find out how long that immunity lasts. But it is so the lower dose gets the same level of immunity that you see in the older groups.
Here's a question. According to this, the person is stating that according to CDC and FDA and other agencies are saying that the Delta variant is eluding current vaccines. He mentions Israel is reporting the Pfizer vaccine is effective at 17%. How can we expect this vaccine to exist as a deterrent when these rates of effectiveness are so low?
So this has been, something that we've all, I think, been very curious about. So no other countries have found the same low rates as some, because there really is this some data from Israel that shows particularly low. That's not been found in the United States. That's not been found in most European countries or Asian countries that, or really any of those other countries. There clearly is more, quote, breakthrough infection with the Delta variant. So the most important aspect of the vaccines is they prevent severe illness and they prevent severe outcomes like death. And that's really our goal. If and when we have, and we're getting, more treatments, but ideally it would be great to be able to prevent infection. But if we could treat infections very, very easily and readily and feasibly in all ways, it would make vaccination much less important and arguably at some point not important. But in the United States, the Delta variant has still been very, very severe outcomes have been decreased or prevented almost entirely with our current vaccines, though not evenly. So the Johnson & Johnson single dose vaccine is really not been as effective. And that's why, independent from any of the conversation about this age group, it's recommended that people who, and again, that's 18 and up, but that people who had the J&J, because it is not as effective against the Delta variant.
If I could add, the study of the 2,200, as Dr. Walker noted, 91% or 90.7% to be exact, of the individuals had no infection at all, even the less severe. So that is, it's a smaller group. We'll see when we have a larger group to look at, but it's encouraging that it works that well for all types of infection in this age group.
One of the questions that we often get from folks, and I have questions here about long-term side effects, about effects of impacting menstruation in girls and women, impacting sperm counts in boys and men. What does the science say about the long-term impacts of vaccination?
Well, we don't have particularly long-term information at this point because they're new, nor do we have particularly long-term information about the infections as well. Couple caveats to that. Historically, all significant long-term vaccine issues that have arisen since the very first vaccines, there was a signal, there was something that was obvious, or not obvious, but that was notable, particularly if you were looking hard for it, in the first 2 to 3 months. So the likelihood, though not zero, but the likelihood of finding a late long-term effect of the vaccine is in general small. Now, the issues about, and concerns about fertility and menstrual changes, absolutely critical to look at because we're talking about children and we're talking about adolescents and young adults. And we do have quite a bit of data now about adolescent age group and young adults in terms of fertility. And there is no reduction that has been seen in fertility among vaccinated individuals compared to non-vaccinated individuals. And that's holding true across country, across the world, and is incredibly reassuring. Early on, nobody really knew, was this a great idea to immunize pregnant women? Turns out, pregnancy in and of itself is a huge risk for COVID infection. People who are pregnant and have COVID infection also have twice the rate of stillbirth. That is not seen in vaccinated people. The miscarriage rate is not higher in vaccinated people. So fertility rates, there's no change. And at this point, we have tens and hundreds of thousands of data points worldwide and in the United States. So fertility, there has been no noticeable change. Sperm counts specifically, I don't know that data, but in terms of couples conceiving or people conceiving, that has not been an issue. Menstrual changes, this is a fascinating topic. This is one that we don't have all of the answers yet. We probably won't for quite a while. We do know that in the last 20 months, there have been far more adolescents and women with irregular periods and quote, abnormal periods or changes in their menstrual cycle. This is, some of that is absolutely stress related. That's quite true. There are several possible physiologic mechanisms by which menstruation really could be altered. None of them, however, are plausibly severe, and none of them are plausibly going to lead to other things. But absolutely, I think that it's quite possible. I mean, anecdotally, it seems to be, something that is been validated. And there are ongoing studies. That was not part of the original fertility but in the early studies, they weren't specifically looking at menstrual changes.
I would like to go back to just about for pregnancy, the risk for both the pregnant woman as well as for the child. I think early on there was a hesitancy by all the various obstetrical societies about really supporting vaccination because there wasn't really an understanding of whether there was a risk or not. And the evidence came out such that it was clearly that it would help save lives, and that that women who got COVID were at risk for themselves as well as for their children or for the newborn. And I think there's still a resonance out there, maybe in social media, whatever, about belief systems that there is a risk. And I think the data is sufficient to say there it's been looked at, and all of the various medical groups who provide labor and delivery services, at national levels, the equivalent, are fully supportive of the vaccination and recommend it.
Interestingly, there's just been so much data and information about all of these vaccines because, worldwide they've been given to over 8 billion doses, blah, blah, blah. In the US, there are many healthcare workers, myself included, are participating in a variety of studies to get information about vaccination and other changes. And young physicians who are in training, reproductive age. And so when vaccines were first available, that was a group that was particularly asked to be involved with studies and follow-up. So resident physicians who have finished medical school but are doing their ongoing training in their field of choice, as well as young physicians who are out in practice. Everyone was asked if they could and would participate in some kind of study, and much of that is just is gathering data. Some of it is I get my blood drawn every 2 to 3 months, and they're looking at a variety of things and assorted things, and I don't have the results of that, but I'm very happy to participate in that. But so I think early on, being cautious and dragging one's feet is absolutely appropriate. And then as we have new information, that's, I think what's also been so hard about this entire process is when you know nothing and you're kind of making educated guesses, and some of those educated guesses turn out to be incorrect. And then the information and recommendations shift. And so everyone has just, felt like there's been whiplash, do this, don't do this, do this, don't do that. At this point, we have a impressive grasp on the physiology, on the vaccines, on the illness, and clearly there is much more that we can learn. But the amount of information that has come out is more than, with other illnesses came out in decades.
We have a question about, so what is the cost benefit analysis of using Pfizer products for our children? And I'm assuming they mean cost benefit as the risk factors versus the benefits of vaccination.
Yeah, that's exactly how I think most of us think about it. When I'm talking to families in my office about vaccines, and to echo what Dr. Gordon said, my role as a pediatrician is to give people accurate information, up-to-date information, to answer questions, and it is also to give people my opinion. However, I think that an opinion can be, there are many ways to accomplish many of the same goals. That said, Pfizer specifically, I think I'm just going to go with Pfizer because we're talking about Pfizer in this age group. Looking at cost benefit is a very complex thing when it comes to something like this, because there's there's individual levels. And how do you measure mental health? Like this is why I think mortality has been something that's been so focused on, because it's something that is measurable. It is something that we can count. We can count hospitalizations. We can count hospital days. We can count, deaths. We can count cases of X, Y, or Z. But it's very difficult to quantify and put a value on so much of what has made it so difficult for children. And different people are not going to assess the risks and benefits of many things equivalently. At this point, we can say, based on current data and scientific evidence, the vaccines are incredibly safe. There has not been a single actual confirmed, validated death from a vaccine in the United States. There are lots of anecdotal cases or reports then that have not been actually validated at this point. It is critical to keep looking at those things. We don't want to miss anything. The last thing any of us want to do is give, incorrect advice, especially, again, children, babies. Everyone I work with in my office is a parent. All of us have kids. In addition, there's the individual benefits and risks. There's also the family, there's the community. It is bigger than just one person. So on the vaccine side, and the consensus in the pediatric community and scientific community really is seeming to be that these vaccines are incredibly safe. We do at this point, I think, can say confidently and accurately that they are safe in the older group, and there's no reason to think that they would be different in terms of safety for this group. So safety, very, very, very good. So the downsides, and very, very effective at preventing bad outcomes. Again, hospitalizations, illnesses, deaths, and long COVID. Long COVID, we don't know. This causes tremendous cardiovascular disease. We don't know what 20 years from now, 40 years from now, 60 years from now, what this, a childhood infection with COVID could mean for somebody's heart disease risk.
If I could add a couple of things, agree with everything Dr. Walker said. The risk of dying for this population is probably very low. It's something like 1 in 100,000, so it's very low.
Very low.
But the risk of getting the infection by not being vaccinated and having to be out of school and being isolated is not low at all, and it's quite real, and you diminish that by 90% if you're vaccinated. And as Dr. Walker said, this is not just about the individual. This is to protect your other family members that may be more vulnerable, protect the other students in the classroom so that there are a number of children with different health issues that they are at higher risk if there's more COVID in the classroom. And it's protecting your older loved ones too. So it's not just about the individual, it's a broader community protection where there's added value. And younger children can pass it on, and we can have a prolonged sort of rollout of this pandemic if we don't get a higher percentage of individuals immunized also. So I think people have to take it at their level, but it's also does provide a community benefit.
What are the side effects of the vaccination for children?
I'll start. And then, first of all, the symptoms tend to only be a few days. Typically, you'll have soreness from the injection site or some achiness, some fatigue, possibly fever. Those are going to be the most common side effects that are likely to present. Dr. Walker? Really,
I think you said that really well. It's primarily local infection, so soreness at the injection site, and then some fatigue or malaise, low-grade fever in the next 24 to 48 hours. And we'll know a whole lot more very quickly, because the folks that are not ready to get their kids vaccinated, are going to benefit from the folks that are eager. And so we'll have a lot more data very quickly for tens and tens of thousands of kids in this age group.
What is the difference between emergency use and full approval of the vaccine? How does that change things?
I would say the emergency use is where we've had our study groups studied. There's been a review. There's been all this formal review, but the full approval, I think, will be taking all the data from our experience of it in the field and assessing the risk benefits. I remember many years ago where a vaccine that was put out into the field was taken off because of further review that they found that there were some issues. But at this point, I think we've had, at least for the older groups, sufficient data and sufficient experience that I think there's a good understanding of the risks associated with the vaccines that we currently have. Dr. Walker?
Yeah, I think it just provides for that amplitude, for the bigger numbers, and to look for the smaller number studies can identify things that might be rare but not exceptionally rare. But in the emergency use authorization period will enable us, and the assorted monitoring groups and clinicians, to look for the rare things and the things that didn't pop up. And it's just, again, being very cautious, slow, careful, thoughtful. We really do want to tiptoe in terms of protecting kids, but at the same time, we feel urgency because of how devastating this has been for kids. And so, the pediatric community is as a whole extremely pleased with the option for school age kids to be vaccinated and their own.
What is the vaccine effectiveness after 6 months or 9 months?
We don't really know. We know that the levels are very, very good, through the duration of this study. Same with what was the experience with the older age groups. But we only know the duration of these studies, which is why ongoing surveillance and monitoring is going to be really critical.
So we have a 6 to 7 month experience with this group. And so I think the next 6 months we'll have a better understanding if there's sort of a drop off similar to what we see in some of our older groups.
Moderna is also in the process of getting authorization for this age group. Have you heard when this may happen? And as a pediatrician, do you have a preference of Pfizer or Moderna?
Well, Cal, so what I know that there are ongoing studies. Moderna's preliminary data is complete. I don't know for sure when they're planning to have it all analyzed adequately for submission to the FDA for approval. But I've heard that it's within the next couple months. It's an excellent question. I am a strong believer, particularly early on, whatever vaccine people could get, that's what they should get. At this point, it's been fascinating because, the first wave, the second wave, the Delta variant, there's very minimal difference between the two mRNA vaccines overall in terms of the most severe outcomes. Maybe a little bit in some ways. I would still say whichever one people have access to is what they should get. I do think that there is evidence for the J&J for the younger kids, and I do see kids that are in college age, and so I have patients who are 18 and up. If they had a Johnson & Johnson, the data definitely suggests that having an mRNA as a second shot boosts their immunity, is more protective than getting a second J&J shot.
If I just add Pfizer versus Moderna, at least for the older population, almost identical in terms of how they present, but Moderna actually provided a higher dosage that they gave, and there have been some studies to suggest that Moderna has a longer amplitude of immunity, and it may be related to the dosage. I'm not sure what the dosage is going to be for this younger group, and whether we're going to see some similar difference or not. But all in all, in terms of hospitalization and death, they have very similar outcomes.
Great. There's a question about what if students who are vaccinated, if there are any other kind of the word the community member uses, benefits, when it comes to the CDPH practices at the school. And currently, if a person is vaccinated and they're exposed to a positive case at the school site, they do not have to quarantine. So if that policy stays in place under CDPH guidelines, which we think it will be, students who are vaccinated would not have to quarantine if they are exposed. The other students who are unvaccinated would be able to quarantine at school if they participate in the testing. We encourage all students, all people who are exposed, vaccinated or unvaccinated, to participate in testing. So that is something that we recommend. CDPH recommends that, but it is required for students who are unvaccinated. Question. We got lots of questions coming in.
I would like to pick out one, if I may.
Okay.
Do you have the VAERS data for those in regards to adolescent adverse reactions? So, and I know that VAERS data has been sort of taken and run with, and even on the VAERS is a vaccine adverse reaction, and it can, if there's a data repository for nationally that any sort of potential side effect, whether it's potentially related to the vaccine, is reported. And on the website of the VAERS website, it will say that if you just take the data as it is, it's not necessarily a reflection. It could be potentially not related to the vaccine. It could be potentially incomplete, inaccurate, or coincidental, or unverifiable, and that's what they have on that. My understanding is that for the 45 million cases of vaccination that have occurred in the 6 to 17-year-olds, 19 deaths were reported on VAERS. Every single one of those deaths was reviewed by the CDC. Those particular 19, they did not find any relationship of those deaths due to the vaccine. And so there's, I think there's been a lot of kind of misinformation that kind of amplifies the risk and the concern, but at least for our 6 to 17-year-olds, this has not been proven to be the case, and there's a lot of interest. Let me just say, people are definitely trying to look at the VAERS and see if there is any causal relationship with this. Dr. Walker, I don't know if you want to add to that or not.
Yeah, I mean, so that is one sort of leg of the surveillance stool, and surveillance meaning looking for, and actively trying to make sure that something isn't missed and something isn't come up, and it is because everyone is encouraged to report things that we think could possibly be related to check it out. It's only after it's gone through the process that information is, really, and has been vetted, that's as accurate. So I agree it's important to look at all of that, and that is a critical portion of surveillance and ongoing assessment and reassessment. But at this point, I think it also has been kind of used it sometimes a little bit disingenuously.
There's a question, several questions actually about VAERS data, the VAERS website where people self-report. The question is, what have you looked at that data? What does that tell you? What are your thoughts on using that data as kind of a source?
I don't think it's a good thing to look at initially because, again, anything and everything can be reported, and then it's only after looking at it. So for example, there was a person in one of the earlier COVID age group vaccines that was struck by lightning, and that was reported on VAERS, but, being immunized did not cause him to be struck by lightning. And so, people have different, I think, slightly different motivations at times, and different thresholds for things. So I think the problem with looking at VAERS, it's so preliminary. You really, it needs to look at after cases have investigated and it's gone through its entire process.
Just to add to that, I think the take-home message is VAERS data in total is it's a mixed bag, and it's of different things, and it's going to take review. And at least for this younger group, for the ones that were potentially, there were only 19 that were reported for this younger group, and there was a due diligence first pass. But I agree with Dr. Walker. There will be continued review of this and just tracking down each one and trying to understand if there's a causal relationship.
Here's a question. I don't know if it's kind of if you were to have a 5 to 11-year-old relative, would you have them vaccinated? I can tell you that I'm eager to have my 11-year-old vaccinated.
So I have a 5-year-old grandson, and I'm eager for him to be vaccinated. I'm grandfather, I'm pediatrician, so it's really going to be the parent decision. But I will give them my advice, and then they will need to make their decision. But again, I feel like there's the opportunity to work this through with your people you trust. Hopefully you have trust in your pediatrician or your family physician, where you can have this discussion and reach a decision.
My kids were middle school and high school when this all started, and by the time that vaccines were an option for them in their age group, my older one was 18, and I strongly recommended that he get vaccinated, and he did so. He chose the J&J, which, again, his decision, we talked about it. I gave him information and what we knew at the time. I have a younger child in the 12 to 15 age group category, and she, on her own, absolutely wanted to be. And the day that it was eligible, I got online to get her an appointment scheduled. And the relief for both of them and the relief for the rest of our family, I have an elderly immunocompromised mother. So their grandmother, they really couldn't be around. Yes, she is immunized. She is immunocompromised because she's receiving chemotherapy. And, it's not the same to stand in a backyard and look at each other. So it was life-changing for my kids and for my family. And yes, if every pediatrician I know, all over the place, we have the day of the committee meeting, people, I know people who were following, the hearings. I just checked in periodically, at lunchtime and the end of the day. But that night I'm reading and, trying to learn as much as I can. A year ago, if somebody said, are you going to get vaccinated or are you going to get your kids vaccinated? I would have said and did say, I don't know. I need to know as much as I possibly can. I need to talk to people. I need to, listen to people. I, have done so and continue to do so. I think it's it's an imperative thing for me professionally as someone who is, I get asked about this, what families, think, what they should do. And I am a cautious person. And so at this point, I'm very comfortable. And in fact, as is obvious, I'm extremely pleased that these are going to be an option for our kids.
There was a question about the process after receiving the injection at a school site and what kind of monitoring is going to take place. And I just wanted to share that the teams that Inspire Diagnostics is putting together is going to include a registered nurse who will actually be administering the vaccine, a technician who's going to be doing the data entry and registration, and an EMT who's going to be observing the children after the injection. Naida, is there anything you'd like to add?
Well, also that not only are we hiring very experienced staff who will all support each other with the different skill sets they have, but that there will be an EpiPen or some form of an emergency response in the event that someone has a reaction. So you'll be in good hands.
In terms of the older age groups, the study rates of anaphylaxis, which is that an immediate, very severe allergic reaction, they were very rare in the studies, but have proven to be even much less common in quote real world, and very treatable with appropriate staff and materials.
That is correct, Doctor.
Help me out here, Dr. Gordon. I'm trying to get through as many questions as I can. There's a question about the vaccination preventing transmission. Does the vaccine, in fact, prevent transmission?
It doesn't prevent it 100%, but it prevents it to a very large extent. It minimizes prevention a lot. But the Delta variant has proven to, there has been more breakthrough transmission because more vaccinated individuals have had mild or low or asymptomatic infections that have been able to, so less severe and less frequent transmission. So it doesn't prevent it 100%, but it's way up there, 80s to 90s.
There is a question that you asked, Ferris. Hasn't Delta strain infections declining the past several weeks? Why implement vaccination at this time? Absolutely. So we're on the downside of the, actually, I think are 23% less than we were a couple of weeks ago in terms of cases in the county. We're definitely going down. But if you look at, we've had, 4 waves of this? There are 3 major waves so far. And last year we were actually about the same case rate of COVID. And then we went into a very big winter surge that was actually much larger than the Delta surge. We don't know what we're facing this winter. The good news is that a large proportion of our community has been vaccinated, but we don't know what we do expect to go back up again, and probably not that far out. Potential, we don't know when it's going to go up, but the expectation that we will go up. We don't know how high it will be. So the expectation we're going to have probably more flu than we did last year, as well as another increase to some degree.
Here's a question about natural immunity. It asks, how do you plan on handling children who are naturally immune, given the current studies out of India and the UK showing more robust long-term immunity with natural infection?
So that's, again, we are fortunate that there is more and more robust data and more robust information and multiple studies and multiple things. Even the term natural immunity is kind of an interesting phrase. And it's used and it's being used in general in this context to mean immunity following having been ill, having had an infection, as opposed to vaccine-induced immunity, which is also natural. The vaccine is basically it's the same mechanism. It's the exact same mechanism. It's our body responding to an antigen. And our body, when we are infected with the virus, it's responding to the antigen that, the proteins in the virus. Whereas with the vaccine, it's our body responding to the protein of the spike protein that's in the vaccine. So they're both natural immunity. But, immunity following infection versus immunity following vaccination, there are some, small numbers of studies that suggest and do show, including the ones that I think this person is citing, that, quote, natural immunity is more robust or lasts longer or more effective. That hasn't actually been found in most of the studies. Overall, it really does appear that natural immunity from vaccination is more effective in preventing recurrent or preventing infection and, again, those severe outcomes. And we do know that immunity wanes regardless, meaning it decreases. So people who've had infection are actually more likely to be reinfected than people who were vaccinated. And this is being seen more and more as there's more time in which people have been vaccinated. So if someone has so we agree that if somebody is immune, they're immune. But it's probably, it may be temporary. And so that's why we also postpone vaccination for somebody who has had an infection.
If I could just add, I don't view it as one or the other. Studies have shown that if you've had natural infection or prior infection and you get immunized, your immune response, your titers are just super high. And so that by getting the vaccine, you are going to have a really, really strong protection by adding the vaccine to your prior infection. So there have been good studies to show that you really have a superb response with the vaccine.
It's kind of that Swiss cheese model again. So layering on levels of support. And so, the goal being to not have it make anyone sick and not have it spread to other people.
There's a question about the flu vaccine, and if there's people should wait, should they take it at the same time?
If I could take that one. So for older groups, there's been general recommendation and observation that getting flu vaccine at the same time of COVID is not contraindicated and is perfectly fine. I do have friends who have had those two vaccines at the same time, and they've been pretty achy. So I think that there is that potential. Given the fact that we don't quite know with the younger group, everything suggests that it would not be an issue. But I think at this point we don't have a CDC recommendation. We don't have necessarily the jury deciding on that one. So I think in the interim, waiting and probably doing it separately until there's a formal advisory might be the way to go. That would be my response.
There is a question here which we often also receive in the school sites, which is what about alternative treatments that exist as opposed to that would protect people from COVID infection as opposed to vaccination?
So, I think of it as so prevention, I think, is, again, as a pediatrician, we try to prevent issues from developing before they come up. So, I think that is optimal. And I think that not getting sick is better than getting sick. Treatments, so the term alternative is an interesting word choice because, there's things that, and we're still, we got a long ways to go, but treatments, there are some that we know now are effective. There are some that we know are not effective. And there are some that it is unclear, and additional study and time and data is needed. There are We know that dexamethasone is, for hospitalized patients, so there are definitely anti-inflammatories have dramatically helped. Other preventive things when people are sick, we know that because it tends to cause blood clots, people are prophylactically or preventatively treated for blood clots in the right clinical context. There's been lots of hope and optimism that, this one's going to be, maybe this will work or maybe this will work. And so, again, in that slow, cautious, do no harm approach, I think that it's been critical to look at things objectively and carefully. And fluvoxamine is something now that looks like it really may be, it's one of these, quote, repurposed medications. And it's still preliminary, but some of that is quite interesting. At different times, there were some other things that seemed like maybe they might be interesting. The quality of the studies also matters. There's been, some quote data that's been published that has not been well designed or had been done in a way that didn't actually show with what they thought they were, maybe finding. So I think that, we continue to need to find effective, treatments. And I am hopeful that over time we will have easy, effective treatments. There have been several that have come into popular favor in some communities that have not been shown to be effective, ivermectin being one of them, and good Lord, I can't speak. You know what I mean? And hydroxychloroquine, I had trouble saying it. Those, have not been borne out, and there's, significant troubles with the design of the ivermectin studies in particular, and they have been re-reviewed, and additional studies. And so, unfortunately, those haven't quite panned out. But I think, keep looking for them. Dr. Gordon, what do you think?
I would agree. And I do think that because things can be amplified in social media, things have a life of their own. And but there have been a number of great and various studies that have shown that the ivermectin, as well as hydroxychloroquine, don't work. We know that the monoclonal and polyclonal antibodies work, antivirals, the dexamethasone, all of those have a role. But we know that vaccinations actually is a better line of defense. And all these other things is like a response mode of trying to keep people alive or from getting much sicker. And it's far better if we can have natural immunity already with the occur with the vaccination, so that people have that immune capability the moment that they're exposed to the virus.
All right. I know we have lots of questions, but we are getting to the final point of our presentation tonight. I want to thank everybody. I'm sorry that we were not able to get through everything. Looks like Neda has something she'd like to share. Go ahead, Neda. You're still on mute.
I think, first of all, I see so many people attended tonight's town hall meeting, and I want to applaud those parents. I'm sure you not only have questions, but you have anxiety. But as a nurse who has vaccinated a lot of people, including children, I want to just remind you that when you decide that this is something that is good for your children and your questions are satisfied, that the parents' anxiety transfers into the children. So I think it's important to have that conversation before you even show up at the site, and be excited about it and tell your children what COVID is and why this vaccination is a good thing. And especially for the younger kids, bringing maybe a favorite toy, a security blanket, or something like that could be very calming. Because not only for them, as they're not resisting the vaccination, but for the rest of the people in line who will be seeing a very traumatic reaction from the children in front of them. So just something to remember, that our anxiety is very palpable to our children or grandkids, and it's good for us to not only address but try to calm down our own anxieties and look at this and treat it as a very positive experience that you want your children to experience. That's all.
Thank you so much, Naida. And we're so grateful to all the parents and community members who came. We are doing our best to be as transparent as possible. Our schools are going to be sending out information about different options that are going to be available to parents to decide if they want to offer to participate in this vaccination effort. We're going to be, there's going to be some options at schools, but as we presented earlier, lots of options in the community at pharmacies, at clinics. And what we recommend is really work with your doctor, your own pediatrician, and they will likely have access to the vaccine as well if you are going to choose that. I'd like to give a shout out to all the district superintendents. Thanks for so much for being here and joining us and supporting this effort, supporting our effort to reach out to our community. And a big thank you to Naida from Inspire Diagnostics, and of course, Dr. Raylene Walker and Dr. Gordon. Thank you so much for being here and participating in this forum. We hope to continue offering information to the community and engage our community and our parents as much as we can. And we're so grateful for your presence here tonight. So with that, I'd like to thank you for your participation tonight and say good night to everybody. Thank you.
Good night.